welcome to the show. A Medicare glitch could cost thousands of patients their legs and ultimately their lives. It impacts people whose leg pain turns out to be a circulation problem called peripheral artery disease, a condition that in advanced stages is more prevalent and deadlier than prostate cancer, colon cancer, and breast cancer combined. 3 in 5 people who suffer a heart attack have peripheral artery disease or PAD, and many don't even know it, if at all, until it's too late. Right now, doctors treating these patients in office-based labs across the San Francisco Bay Area, California, and 23 other states are seeing claims denied for critical limb-saving procedures by Medicare contractors, Noridian and Novitas. Today, we're finding out what's going on. My co-host, Dr. John Phillips, is on call. So joining me as co-host is world-renowned vascular surgeon and SiriusXM Doctor Radio host, Dr. Todd Berland. And also with us are Dr. Elliot Adams, a vascular surgeon directly impacted by these denials, and Dr. Bob Tahara, past president of the OEIS, who is on the front lines with Medicare trying to fight for all of our patients and all of our doctors. So welcome, everyone. Welcome, Dr. Berland. I want to start out and really get your initial thoughts before we jump into the deep.
Yeah, so this was just brought to my attention. I'm based out of New York. I'm a vascular surgeon, like the others on this call here. And for our listeners, really what we're talking about is treating peripheral arterial disease in the outpatient setting, the office setting, which has really revolutionized how we're treating these patients. We've been doing it for about 14 years at NYU. I'm director of outpatient vascular interventions. And we've been doing these procedures for a long time, knowing very well with Medicare, there's no prior authorization process. We do the procedures that are indicated and we get paid for services. We do know with other insurers and payers, there's a pre-auth process, but that's never been the case with Medicare. And when I hear that other states are not getting reimbursed for these procedures, these are very costly procedures. The devices are very expensive. Stents, whether you want to use an atherectomy device, there's definitely a cost associated with these. And for doctors to not get paid for these procedures is going to be a big, big problem.
Yeah, how so? Dr. Tahara, how is this a big, big problem that Dr. Berland describes?
So I think Dr. Berland hit on the fact that oftentimes the devices that we use to treat and save limbs, especially in the office-based facility, are pretty expensive. What a lot of folks don't understand is that when you get treated in an office-based facility by a physician who owns that, part of the physician is liable for all of the materials. And unlike when I'm in a hospital and I do a limb salvage procedure, the devices, every wire, every stent, every atherectomy device, every intravascular lithotripsy device, everything, every Band-Aid, actually I have to pay for. So the reimbursement that we get either from insurers or from Medicare, that doesn't really come to us as physicians. That is really fundamentally designed to offset the costs. So what ends up happening is these very, very expensive items, the physicians have to actually pay for and essentially front or float this money. And then we have to wait for reimbursement from the payers. And I think anybody who's ever run a business can understand what I'm saying, that if you have to spend, let's say, $100,000 a month for equipment and consumables, and now all of a sudden nobody's paying you for a month, that's a huge problem. And the issue is if we don't have that, we can't pay our staff, we can't pay for electricity, we can't pay for the maintenance on the machinery, and we can't pay for more supplies to save more legs. So the problem just keeps compounding itself.
Bob, do we think that this is going to be a delay in payment or no payment at all? Any insight as to where we're going with this?
So I would be very, very confident that there will ultimately be payment rendered. And the reason I'm confident of that is Medicare, CMS, the Center for Medicare Services, has already valued as part of the physician fee schedule payment in the office-based and the ASC and the hospital outpatient arenas. It's already been done. These Medicare Advantage contractors are legally obligated to pay those services at the Medicare rates. But what we're seeing is how they're administering them, whether this is, gaming the system for float or whether this is an honest error, although that one evades me a little bit since they've had years and months to prepare. I do think eventually people will get paid. But that doesn't lessen the severity of the problem at all, Todd, because as you well know, running a lab, there's a huge cash flow crunch. And it's not like the companies that sell us or provide these devices, or indeed our staff. I can't tell my staff, hey guys, come to work for a month and don't get paid. They've got families to feed. They've got electricity to pay. And up here in Northwest Pennsylvania, we need heat.
I want to bring in Dr. Adams here. I am really, you're the first one that I actually heard about this from. I saw it on your LinkedIn. Describe the situation and what you're experiencing.
Yeah, so the impact to those of us out here in rural areas, I'm in rural Idaho, I think is especially severe because we don't have enough surgeons to treat all the patients with critical limbs. At the hospital, my partner and I spend most of our time treating carotids and aneurysms and things that can't be treated outpatient. Before we started this lab, had around 90 to 100 amputations a year in the hospital. Now we're down to below 20 amps a year in the hospital because we can treat these patients so much more efficiently in our own office with our team and our devices. And it's just a much more effective process for getting blood to the foot and saving the leg. We can only do that as government contractors with Medicare if we are receiving reimbursement for those procedures. And since January 1, 2026, we received no reimbursement, and we can't remain solvent for more than a few months like that, which means these patients will go back to the hospital and wait weeks to months for their procedures, and amputation rates will rise as a direct result of it.
Right? Time is tissue with these patients.
Correct. Exactly.
Well, coming up next.
Yeah,
right
often we're in situations where we're treating patients without authorization with the hopes that we'll get reimbursed on the back end, because you got to do what's right, but you can only do what's right for so long because you've got to remain solvent. Just like Dr. Tahara said, you've got to pay your staff, you've got to pay the employees, you got to pay the electrical company to keep the lights on. So the money has to come in.
In the Navy, hope is not a viable tactical plan, right? You can't hope
Right.
that you're going to stay open.
No, and these patients are really reliant upon you, because I know with our Lifesaver hotline, we already, have been getting so many calls with the Medicare Advantage plans issuing delays and denials for these patients suffering from peripheral artery disease in the advanced stage known as critical limb ischemia, where they're up all night long with this debilitating rest pain where they have to dangle their legs over the side of the bed and pace in order to get through the night. I mean, this is no joke when it comes to PAD, and these patients should not be left to suffer. So coming up next, right here on the Heart of Innovation, we're going to tell you what we've heard so far from Noridian and Medicare, what silence may mean, and whether this is truly a billing glitch or something much bigger that could permanently reshape where limb-saving care is delivered, if at all. So stay with us. Don't go away.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just let
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should, because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for.
Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Hi, everyone. Welcome back to the show. Dr. John Phillips, my amazing host, is on call at the hospital. So pinch hitting is my amazing guest co-host, Dr. Todd Berland. And today we're talking about a Medicare billing issue that could force hundreds of office-based labs across California and 23 other states to shut down. That would leave patients with peripheral artery disease, a condition more prevalent and deadlier in advanced stages than prostate cancer, colon cancer, breast cancer combined, without access to advanced limb salvage care in their communities. We reached out to Noridian, which is one of the contractors in question, to Medicare, one of two. It's Noridian and Novitas. And Noridian actually just referred me to Medicare for comment. And as of airtime, Medicare has not responded, even though they said they would respond to media requests within 24 to 48 hours. Bob, you've been on the front lines with Medicare for years. How do you interpret this silence?
Well, I think you've got two separate issues here, Kim. The first issue is the contractor, and the second issue is CMS or Medicare itself. And again, there are tons of hardworking people who try to administer the Medicare program and get folks that are over 65 care. Like, there's absolutely no question about this. And I really don't want this to devolve in anything political, but I would rhetorically say, do we really want our healthcare run solely in the United States by an agency that has service akin to the DMV that we're all used to? And that's just the reality. The reality is it's a large bureaucracy. It's extremely complicated. And so part of, I think, what you got is not necessarily overt malfeasance or avoidance, Kim. I think part of it is actually just the way the system's designed. It is not user-friendly. It's not even user-friendly for us. And, God, we've got decades just between Todd and I before we even add Elliot into this mix, right? So it's difficult to deal with. So I wouldn't read too much into the CMS silence from DC. I do give the current administrator some credit. I think he's trying to make some changes there. Dr. Oz, we'll see where this plays out. And I'm going to give him some time before I pass judgment on that. In terms of the contractor itself, I mean, they certainly could have responded. I think referring it to CMS is a bit of a delay tactic and quite frankly, a little bit disingenuous. The easiest thing could have been just to hit that head on, but my guess is they're not prepared for this onslaught because I think they weren't expecting a lot of people to raise a lot of noise so quickly, like you have on this show.
I'd love to ask Bob and Elliot this question. Do we really understand the scope of this problem yet? We've got two of these managed Medicare plans. I don't even know if we treat lots of plans in New York. I don't know if I've even gotten to all those plans. We're still in the month of January, so I don't know yet what I don't know from what's going to get reimbursed and what's not. Do you guys feel that there's others out there that may also follow along and not pay?
Good question.
For sure.
So Elliot, why don't you tell how this all came to light for you guys?
Yeah, so Medicare, traditional Medicare is always our fastest payer on a revenue cycle basis. It's usually about 15 days from submitting claims to getting paid from Medicare. They're very consistent, unlike these Medicare Advantage plans, which is a whole other ball of wax. Immediately on the days we were supposed to start getting paid for our first case of 2026, denials. And this is just with traditional Medicare. We haven't even seen the Medicare Advantage patients' claims coming through yet. I'm kind of assuming at this point that problem is going to extend to Medicare Advantage because those plans are never easier to deal with than traditional Medicare. They never pay faster. They often don't pay at all, commonly deny, and you have to fight it on the back end for months. So I think this is just the tip of the iceberg.
Wow.
So, Elliot was one of the people who raised this, and actually he raised it not just on LinkedIn, but he also posted on the Society for Vascular Surgery forums that we have that are private forums, which is where I saw it. And because we were at an OEIS executive committee meeting, OEIS as an organization tends to be a lot more nimble. So we were able to kind of immediately initiate a response. But I can tell you that since this has come to light, I've gotten 20 or 30 separate emails from people pertaining to the Medicare disadvantage plans, as well as to many of the commercial payers. And what Elliot just said is really true. What we're seeing is a wave of denials. Partially, there are some system issues where they haven't gotten the codes loaded correctly and they don't understand the linkages and that. So there is a technical component, which I'm more than willing to admit. But it's very frustrating for us to see this because, again, there's been months to prepare for this, and the codes reformulated have been on track for years. I mean, Matt Seidman from SVS and the guys at CPT from OEIS and SIR and SCI, which are other professional societies, have been working on this for years. None of this is news.
Yeah, I don't want to blow this out of proportion, but I think that it is the reality because I'm experiencing it on the front lines with our Leg Saver hotline. We're not blowing this out of proportion. These insurance plans are literally costing legs every single day. I can't tell you how many patients just for Medicare Advantage plans that the delays or denials have led patients to an emergency room where they ended up with an unnecessary amputation. And it's really sad. And I'm concerned that this is literally not going to be resolved anytime soon. And it's going to have a cascade effect. And I think Dr. Adams is right, unfortunately, and Dr. Tahara, to where Medicare Advantage plans are going to see that Noridian and Novitas are literally denying claims, and they're going to say, ooh, this is another opportunity for us to delay and deny claims.
The question is what to do. What can we do? I know, Bob, you've stepped down as just past president of OEIS. I'm sure, OEIS is probably our best chance at advocating for this. I'm the president-elect of VES, which is the Vascular and Endovascular Surgery Society. We could move pretty quickly, and we're nimble as well. You would expect the society, like Society for Vascular Surgery, to be behind us. They have not supported private practice and OBLs like I wish they would have over past years, but this should be in their wheelhouse with their clout to be able to help with this. The question is this on patients? Is this on providers? Is this on media? How do we fix this?
So what I would say to that, Todd, so one thing I don't want to lose sight of, because there's been a lot of strife in the past between these organizations and between, is it hospital-based versus private practice guys, academic guys versus OBL guys. The good news on an advocacy front is that all the major societies really are now pretty firmly aligned. And I really do have to give a positive shout out to the SVS advocacy folks, Megan Tracy and Joe Harani and Yazin Burbai, who really dramatically have stepped up. It's such a marked difference from years gone by. So I'll say that first. But one of the response timing issues, I think, and again, I said it before we were live, I think, we all feel this acutely because we're signing the front of paychecks and we're signing checks to pay for the supplies. Most of our hospital-based colleagues, it's not that they're better, it's not that they're worse. This isn't an urgency for them.
They don't care. I can tell you, as a hospital-based physician.
I mean, I think they care in a very cerebral fashion, but they're not looking at their practice checking account going, I can't make payroll this week, right? And of course, there's always been this fallacy about the OBLs are so rich in money and all this other nonsense. So I think that's really a big part of it. I don't think it's overt malfeasance or anything else. And again, I think the advocacy people are pretty aligned. I think the problem has been some of these organizations, like you alluded to, are not nimble. And so they spend a lot of time collecting data, by which time the problem's already long gone. People are closing, right? So I do think that there's a real focus on the societies that do focus on this to be kind of the canary in the coal mines and really raise these alarms and start the work. And my hope is that our larger, what I call our parent organizations, will follow suit and really support this.
Well, coming up next right here on The Heart of Innovation, we're going to have more with Dr. Adams, Dr. Tahara, and my guest co-host, Dr. Berland. So stay with us right here on The Heart of Innovation on KDOW. Don't go away.
Your type of condition is called critical limb ischemia. It's the most advanced form of PAD, or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to PAD and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with PAD.
And all I heard was, what are we doing here? Just cut it off. And I pulled the curtain back like, are you kidding me?
Do you really want to go through all that?
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Hi, everyone. Welcome back to the show. Dr. John Phillips is on call at the hospital. So Dr. Todd Berland is pitch hitting as co-host. And We're getting some questions coming in online. We are streamed at youtube.com/the @ the way to my heart. Dr. Michael Lalazarian is asking, do we know if the denials also extend to the ASC, ambulatory surgical centers, and not just the OBL? And it looks like Julie online is saying that Noridian is in fact denying ASCs. Would you be able to comment on that?
So the EOBs that I have seen on this specifically have stated that it's a site of service problem. So the contention that Noridian has been putting forward is that these codes will only be reimbursed in hospitals. That is factually incorrect. That is legally incorrect. That is regulatorily incorrect.
And we have another question coming in from Eric. Is there a specific CPT code that you've seen denied in your OBL, Dr. Adams? And is the denial with straightforward lesions or the new complex lesion CPT codes? You might want to explain for our audience what this means for those who are not familiar.
Yeah, so the new set of codes, unlike the old codes, now differentiates between a completely occluded or a complex lesion, which may take multiple hours to cross and treat, as opposed to a stenosis or a simple lesion, which is generally much more straightforward to treat. And that's a very appropriate differentiation. But we're seeing denials across all of those. We've seen it for stenoses, we've seen it for occlusions. I would have to look at my EOBs to tell you exactly which ones, but for sure, SFA stenting of an occluded SFA, which is a very standard procedure we perform for limb threat, is being denied.
Elliot, can I ask you, has anything been paid so far in the month of January?
No, we've not been paid
Nothing.
for any of these. Nothing.
That is amazing. Jeez. That's a big
and
problem.
This is just for peripheral artery disease. We're just talking about opening up the blocked arteries in the legs. We're not talking about, have you had any problems with venous? I mean, I know that these office-based labs also not only do arteries, but they also are able to get the circulation in the veins working properly as well.
So we've not had any reports of the other codes being denied, but the other codes didn't change. So we went from having 16 or 17 codes to 37, I think, or 39 codes. I forget off the top of my head. So it was a real expansion as we went into this straightforward versus complex situation. So it's really only been the arterial codes.
And so we just have Dr. Feldman, who's also commenting on our stream on LinkedIn, saying, beginning January 1st, we have been having significant delays in getting authorizations in South Florida as well, and they've yet to be paid for any of their cases using the new codes yet. This delay on both ends, he confirms, it's causing serious cash flow issues. So we might see some labs in some serious crunch sometime soon. Right now, doctors like both of you, Dr. Adams and Dr. Tahara, out of good faith, you're still continuing to treat these patients. But how long can this be sustainable?
Well, I think Elliot said a couple of months, and I think that depends on each individual situation. You know, a lot of the office-based facilities are run by onesie-twosies. You have a single operator. As I jokingly say about myself, I'm in a three-man group, me, myself, and I, in a rural area in Western Pennsylvania. There are groups that are bigger and have a little bit more scale, so they sometimes have some larger cash reserves, but at the end of the day, it's measured in a couple of months. And even the other thing that a lot of folks don't understand, even if we eventually get paid for this, that cash flow thing. So for instance, in the month of January, I've already loaned money back to my practice so I could pay my staff. Like I've personally given my practice yet another loan to make payroll. That happens. That's like part of the deal when you're in an OBL practice sometimes, because sometimes cash, but this is a more extraordinary set of circumstances.
Can I ask you guys a question, Bob and Elliot? When you forget regular Medicare where you don't need prior auth or pre-auth, when you do have pre-auth, how many days out do you typically start that process? What has your experience been as far as getting the approval from the time of asking for it to getting it? What do you...
I'll let Elliot answer that first.
Yeah, generally a couple of weeks is adequate for most plans, but they're going to deny it on the back end. Medicare Advantage plans, it doesn't always matter if you get prior auth. They're going to find a way to not pay.
And even if you get prior auth, so I'll quibble with Elliot slightly on that. My experience with Medicare Disadvantage plans is that they deny everything up front, and then they send me to a so-called peer-to-peer review where I never get to talk to another vascular surgeon. I'm usually talking to a non-interventional cardiologist or a non-vascular surgical specialist. who then will patiently explain to me why the guy with gangrene doesn't need blood flow. And that's usually a contentious discussion. And after I've gone through that conversation, usually we get approval. And then what Elliot says happens, they come back and deny it or try to claw it back on the back end.
We ended up with, and people, there are a lot of people that just don't believe this happens, but we did have a peer-to-peer review with a gynecologist, an OBGYN. They denied a patient with gangrene, and the patient just couldn't wait any longer. I mean, people do not understand the debilitating nature of this disease. And this patient ended up in the emergency room, and they didn't just cut off his toe, they cut off his entire leg, saying, why delay the inevitable? And if only they had an actual vascular surgeon or a vascular specialist on that peer-to-peer, I think this patient would have had a better opportunity to have that leg saved.
Yeah, and it's interesting, and it doesn't even only extend to this. We're talking very specifically to lower extremity codes. Kim, I've had that exact same experience with carotid revascularization.
Oh, no.
I'm getting denied, and then speaking to, and again, I'm not trying to be denigratory to my gynecology colleagues, but don't ask me about the appropriateness of a hysterectomy because I don't know. So it doesn't make sense that they're telling me about the appropriateness of a carotid revascularization.
And coming up next, right here on the Heart of Innovation, we're going to have more on what we hope is just a Medicare glitch that will be resolved very soon, but what patients can expect and what they can do about it to help support their doctors and help keep their limbs intact. So don't go away. Stay with us right here on the Heart of Innovation on KDOW. Don't go away. Hi, everyone. Welcome back to the show. Dr. John Phillips is on call off Saving Those Piggies. And in for Dr. Phillips, co-hosting is Dr. Todd Berland. And today we're talking about a potential, what we hope is just a Medicare glitch that will soon be resolved that is impacting the millions of patients across the U.S. with a disease that's more prevalent than most cancers combined, known as peripheral artery disease. You get those leg cramps, you get leg pain, neuropathy. It might be poor circulation in the legs. And the doctors who are treating this in an outpatient setting are not being paid by Medicare contractors, Noridian and Novitas. And we are talking to several vascular surgeons about the potential impact of this. But I want Dr. Tahara to reiterate what we have talked about during a couple of the breaks, which is it's not just vascular surgeons. There are other specialties that are impacted by this glitch.
Yeah, there are a whole lot of folks out there who are working really hard to save people's limbs in office-based facilities that are interventional cardiologists and that are interventional radiologists. When, sometimes vascular surgeons kind of get, I hate to say the limelight because half the time people don't know what we do, but when we're drilling down into peripheral arterial problems, a lot of times that's kind of the default terminology that's used, but it is definitely a multi-specialty effort across the United States, thank heavens, because there's not enough vascular surgeons to do it all. And so having more people involved with this is actually a positive.
And so what does this mean for patients? I would imagine that if Medicare is coming to the doctors and saying, hey, you did the procedure, we're not going to pay the bill, that suddenly this is going to end up with a letter to patients who are then going to in turn call going, why am I getting this bill for thousands and thousands of dollars? What are we going to do? What's your best advice for them during this process?
I think most of the practices are going to try and minimize patient involvement in it as we're fighting through this. I think the bigger issue will be if people can't afford to keep paying their staff, and then they will have to cut back on their schedule, and there will be delays, which I think you alluded to in the earlier segment, can directly lead to limb loss. I mean, in a really, truly critical situation, time is tissue. And the sooner we restore flow to that tissue, the better the patient's outcome is going to be. So I think that would be the biggest single thing. I think from an action perspective, what can patients do? Call your elected representatives, your federal elected representatives. And I would loudly complain about this problem because, nothing gets a federal agency to start moving the gears a little bit quicker when 4 or 5 congressmen or senators submit a congressional inquiry. Why is this happening to my constituents?
And I hear on February 11th, there is a PAD caucus that is happening. I'm curious if that's already in discussion to ensure that someone is bringing this up in those 5 minutes that one vascular surgeon or specialist may have in front of them.
Well, I'm going to be one of the people testifying before Congress that day at the PAD caucus, and I'm specifically being tasked to talk about some of these reimbursement issues. Most of what we were going to talk about was the problems that we've had with reimbursements. This is going to take a front seat.
I mean, this isn't an isolated case. We have a great conversation that is unfolding on LinkedIn right now. Dr. Feldbaum is talking about they're having issues with IVUS which is intravascular ultrasound for those, general public that are watching this. Aetna Insurance is doing that, both arterial and venous cases. They're seeing delays and denials with it. They wonder if anyone else is having issues. They said they've always been paid before 2026. It's happening in the OBL and ASC. Another person, Dr. I can't pronounce Palanipian, he said it's not just Aetna, but UHC, United Healthcare, has also been denying IVUS at random for the past 2 years in his experience. Same documentation across, but they're just denying some patients, no idea why. Is this something that you guys are experiencing and addressing as well, or have any idea why they're doing it? Why do they keep coming down on PAD?
So again, I'll let Elliot talk about what his experience with this, but I'm going to make 2 quick comments. I'm going to shut up. The first is what these insurance companies like to do is term something experimental until the data is so overwhelming that it would break your fingers if you got hit with it. And they will use this to hide behind and prevent payment for long periods of time. I had this even locally with a payer for IVUS, the intravascular ultrasound issues, and for venous applications. And they were denying my claims, even though I was on faculty there, and I was one of the lead authors of the pivotal paper that proved that this is what you have to do with every case. The second issue with why does this keep happening? There's been a lot of unfavorable lay press about outpatient treatment of arterial disease. And we've really, I think, in an overzealous quest to self-police and to try and, be a wee bit holier than thou about whether or not people are doing appropriate things, we've basically created an environment of fratricide where it's raised the level of consciousness, and the regulators and the payers and everybody feels that, well, boy, we have to scrutinize this. And it's unfortunate because the overwhelming and vast majority of people out there are like the guys sitting on this conversation right now. We're all doing our level best to try and save these people's legs. So those are my 2 cents on that. Elliot, please, I don't want to take all the time here.
Yeah, specifically on IVUS, I've had the exact same experience with UHC. They deny it routinely. Personally, I feel anecdotally with IVUS, I can achieve a much more technically satisfactory outcome than without it. So I just eat the cost on those patients because I think complex PAD, you need IVUS to really see how to treat the vessels. But
so coming up next right here on the Heart of Innovation, I have a big question for all 3 vascular surgeons on this show, because I am completely baffled that these hospitals are getting carte blanche approval by insurance companies, including Medicare, for amputations as frontline treatment without even following society protocols for restoring or even attempting to restore blood flow prior to any amputation. And yet they're denying and delaying all of these very important limb-saving procedures. We'll get their comments next, right here on the Heart of Innovation. Don't go away.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAT, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link for circulation and pain. Left untreated, your leg might end inflamed.
Hi guys, welcome back. Dr. Todd Berland here in the panel, as you've seen, joined by Kymberlie McNicholas. I'm a vascular surgeon based out of NYU. We're talking about Medicare and the other payers not paying for vascular procedures, for procedures to treat peripheral arterial disease. Don't even know the scope of the problem yet because we're still in the first month of January here, and this is going to be a big, big problem. I kind of want to, but I don't want to, but I'm going to put Bob and Elliot a little bit kind of on the spot, and I'll start. Cost per patient. When you have somebody coming in to treat a PAD patient, and you've done the cost on this, as I'm sure you have. In New York, I know our rent is a lot, but we're paying about just over $6,000 per patient to bring them in for a PAD case where we're having to use all the tricks and tools and things. What kind of number do you guys throw out? Because we're talking about not being paid on these procedures. And when a doctor does this in the hospital, it's just your time that's lost. The hospital eats any kind of cost for something not being reimbursed. But when you do this in the office setting, the doctor's not getting paid and the doctor's losing, in my case, $6,000 per patient treated. What do you guys think from a number standpoint?
It's about 7 out here. As a solo operator, you carry most of the cost yourself, so 7 to 8 grand per patient.
Wow.
So I think that's true here too, Todd. But I
thought it'd be more.
Right. The real estate differential, we're just talking consumables, right? I'm not worried about the real estate differential. The direct costs on a lot of these cases, I mean, when an atherectomy device is a couple of $1,000, and let's say for argument's sake, we're going to use intravascular lithotripsy, and that's a whole nother ball of wax because of how they're charging for that. It's like $3,500
exactly.
Plus. Stents can be anywhere from $600 to $1,200 to $1,800, depending on the length and the manufacturer. Balloons are a couple $100. Every wire I use, 018 wires, it's $200. Right. That stuff adds up.
And this is the scope of the problem, because in the hospital, somebody doesn't get reimbursed. You're doing something pro bono. No big deal. It's your time. It takes an hour. It takes 2 hours. That's it. But now this is a time and money problem. So this is going to be a big issue. And if anything, I've learned about this, and I think we need to shed some light on this on some other sides and other parts of my practice as well.
So I don't understand. How is it that amputations are being approved carte blanche and limb-saving procedures continue to experience this wrath?
It's a really complicated answer, but I'm gonna try and distill it down to a couple of key elements. The first is there's still not enough people doing high-end critical limb or chronic limb threatening ischemia intervention, right? People will do interventions, but doing big multi-level interventions, going down below the knee, going onto the foot, that's still, relatively speaking, a minority of the operators out there that really are invested in doing those type of complicated procedures. So number one is, even among limb salvage folks, there's a graduation in how in-depth or how aggressive they're going to be to try and get that. So there's a supply problem. The second issue on the economic part of it, sometimes the upfront cost of doing an amputation can be less. Now, President Obama famously and erroneously said that the doctor would rather cut off the leg than save it back in the day. And it's actually reversed, because when you start to actually look at the costs of these things and you add all the costs of amputation to it, now it far exceeds the cost of doing a revascularization. So if we take the human element out of it, which we should never do, on an economic basis, it doesn't make sense. But because it's a smaller number for the actual procedure itself, all the other costs, the nursing home placements, the rehabilitations, the complications, the prostheses, get lost in the sauce.
Big problem, but we're going to wrap this up right now. We're going to continue this conversation, though. 2 weeks, we'll know a lot more. SiriusXM Channel 110, Friday morning. Join us. SiriusXM Channel 110, Doctor Radio.